And I'd like to thank Aware for inviting me to come speak with you this evening. So as Frank said, we're going to do the talk first, and I've prepared a talk with information about depression, and in particular I'm going to focus on adolescents, but it is relevant for young people as well. And as I'm very happy to answer any questions that anyone has afterwards. And I work here in St Patrick's in the adolescent service, which is called Willow Grove, and there's an adolescent unit here on site where we look after young people aged between 13 up to 18, and about 50% of our patients have depression, so we see a lot of it in the unit. So what I thought I'd do in the talk is talk a little bit about what depression is, talk about specific developmental considerations for adolescents, and maybe how it presents, because before, when I did this talk, parents were really interested, wanting to know what things to look out for in their young people. Then I was going to talk about the causes, and there are many causes, and discuss some of these, and then the treatment options. So hopefully we'll cover all the important information that you came to hear this evening. So firstly, it affects teenagers. People before used to believe that young people could be depressed. They used to say sometimes young people were just moody, or that they'd grow out of it and that it wasn't real depression, but they really can suffer as much as adults. It has a huge impact on a young person's life if they suffer from a depressive episode, if they don't receive appropriate treatment. It affects them in their own lives, but it also has effects on their families and on society as well. Unfortunately, young people who are depressed are at higher risk of other problems. These can include other behaviours, for example, using drugs and alcohol. There's a higher rate of teenage pregnancy in young people who are depressed, and there's also an association between suicide and school failure in young people who are depressed, as many drop out of school. The prevalence, which is the amount of young people at one time that have depression, would be between 4 and 8%, which is high. And unfortunately, the rates of relapse, which is having second episodes of depression, is also high. And it is also definitely considered a risk factor for completed suicide as well. So there was a recent Irish study. Well, it's not that recent now, but they've done some extra papers on it. It was done in the Mater by the Mater team, and they looked at 723 young people, because there was very little data from Irish teenagers, and they looked at 12 to 15-year-olds in schools in Dublin, and they screened to see did they have any mental health difficulties. And as you can see, they looked at like any type of disorder. There was about a 15% rate of disorder, but depression was the highest, 4.5%, and 1.9% had expressed suicidal ideation as well. Anxiety also came out as a very important disorder, as did attention deficit hyperactivity disorder. The group then, they also looked at different things amongst the young people who had said that and reported that they were depressed themselves. And one of the questions was, would they think about killing themselves, and do they want to, and had they suicidal thoughts or any suicide attempts? And as you can see, the rates are quite high, so it's always very important when a young person is depressed that they get seen by a professional who will check for suicidal ideation as well. About 5% are suffering at any one time, and in general, over a 1 year period, there could be about 8% in the population suffering with depression, and this is actually a little bit higher than the rate considered for the general population. And unfortunately, about 30% of adolescents also develop a substance abuse problem. This could be either alcohol or drugs or both. So the next question is, what causes depression? And this is quite a complex I suppose, illness, and there's actually usually not one cause. So people often want to know, is there one answer or one thing? But there rarely is one cause. And the best way to understand it is that it's a combination of genetic, environmental, and sometimes adverse, and especially early adverse experiences. So sometimes there's a very clear direct stressor, and if there's been something like really severe, perhaps severe bullying or abuse or some major problems at home, these could be precipitants for a young person who's already predisposed to becoming depressed. So two young people could experience the same family life or have experienced the same bullying episode. It doesn't mean that they're both going to get depressed. There has to be an underlying vulnerability to becoming depressed, and then an adverse or a really stressful life situation will actually trigger it in that particular person. So the best way to understand it is that it actually depends on the context for the young person, and the meaning for the young person after it, and what happens after. So that's sometimes parents maybe would ask why, if they have a few children, why one became depressed when, if just say something had happened at home, why it only affected one and not 3 or 4. And that is because it depends on how it affects them and how they interpret it, but also they may have a predisposition for developing a mental health problem as well. Then symptoms of adolescence are really important to look out for. So they rarely will say that they feel depressed. They won't go themselves looking for help, which is why they're quite a vulnerable group. And so if often the presentation is picked up by school and teachers, there may be a drop in school grades or a lot of behaviour problems in school. And sometimes when teenagers are depressed, they come across as more angry than sad. And so often they get noticed maybe for their form being poor, or that they're irritable or angry. And often maybe teachers would ring parents and say that there's a big change in behaviour or something is changing. They may be very fatigued and start saying they don't want to do anything and not want to go out or not do their usual social activities. There's often a change in sleep pattern, and this can be undersleeping or oversleeping, and that can happen. It depends on the young person's makeup, which they're going to be prone to having. A very important symptom is loss of enjoyment of previously enjoyable activities. That's a very significant symptom or significant sign if someone is giving up things that they used to really enjoy and not replacing it with new activities, if they're just losing interest. Self-harming could be a symptom, but it's not always. Social isolation, especially if it's new, that's a kind of a warning sign as well. Inattention to appearance, that would be another sign as well, whether it's personal hygiene or actually not caring, or for someone who previously was interested in their clothes or their hair or how they looked, if they lose that. There can often be extreme sensitivity to rejection or failure, or a very big kind of overreaction to something small that happens, and it may come across as behaviour again, or someone being difficult at home or refusing to talk and locking themselves in their room, and then suicidal thoughts as well. In psychiatry, we use formal kind of criteria when we're actually making a diagnosis, and I just put up what the criteria are, and they're actually very similar to the list I'd shown you of the symptoms. So you have to have to get the diagnosis of a depressive episode. The young person has to have a depressed mood, which is definitely abnormal for that individual. It has to be for most of the day, every day, for more than 2 weeks. So if it's less than that, like if it's a day or two and then they're a bit better, and then they might have a low mood again, it's not enough to have a full depressive episode unless it's practically the most of the day, every day for 2 weeks. And there's usually that loss of interest in previously enjoyable activities, and often a decrease in energy. There's a very common other symptoms which include decrease in concentration and attention. There's often, and this is a really important one for young people, a decrease in their self-esteem and self-confidence, because the teenage years are so important for development in a lot of ways. I'm going to talk about that in the next slide. And if they lose this at this stage, it can really affect their ability to fit in with their peer group and with their friends. They often have ideas of guilt and worthlessness. They may have a pessimistic view of the future. Ideas of self-harm, disturbed sleep and appetite usually goes down, even though in some, as I mentioned earlier, it might go up. Or they may actually have no change in appetite. It doesn't have to be one of the criteria as long as you have most of them in the 2 out of the first 3. So developmentally, it's a very intense world for adolescents. They're trying to fit in. They're influenced by their peers. They're watching the media. They really want to be accepted. They need to have some identity. And friendships during the teenage years are more important for many than anything, more important than family. And it's often during those years that you know least about your teenagers, because they're actually trying to grow up and become independent and autonomous and not tell you things. And it's a really, really big concern if they become depressed during this time. There's a lot of experimenting that goes on at this age, and it's important for young people to be able to try things out and see what way they want to live and how they want to interact with the world. And so if they miss that opportunity, so if they had an episode of depression which went on 6 months, they'd miss a huge amount. Like it could be a significant part of a school year or a really important experimental stage that they need to be at. So I've mentioned that the causes are complex and there's more than one cause. So familial influences can be important if there's a long history of high expressed emotion, which is emotion that is negative or critical or hostile. This has a very big effect on self-esteem, coping skills, and can lead to a depressive episode. In Ireland, culturally, women often complain more than men of depressive symptoms. There's a pattern of men maybe using physical symptoms or trying to cope by themselves with alcohol when they're depressed, whereas women are more likely to help seek, and it's actually the same with girls and boys as well. There's some psychological causes as well. If there's repeated losses or situations when the young person feels helpless, and if they feel that there's no escape, so if something bad is happening regularly, so it could be a very common one for young people is bullying. If something is happening every day, or every time they get on the bus, or every time they go into school at lunchtime, if it's happening again and again and nothing is changing and they're not getting help, that can actually lead to a really depressed type of thinking and a sad feeling that they're no good and that nobody likes them, and unfortunately that can actually lead to significant depression. There's definitely a genetic influence as well, so genes are important as well. So if a parent has depression, studies vary. They say between 4 to 8 times more likely to have a child who's depressed. And then if you look at twins, so identical twins, research has shown that the rates are 45 to 50%, and identical twins share their genes. So that shows that it's not just genetic, because if it was, it would be 100% in identical twins. So the rate is 45 to 50% in identical and 25% in non-identical twins. So what could be inherited is actually that vulnerability to having a depressive episode, and then the way we understand it then is that environmental stressors may trigger it in certain people. So often people think that you either have to be sad or just really quiet and low to have depression, but we know that irritability is a really important symptom, and so is anger. A lot of people present in depression with mood swings, and often people are worried that that means that they have bipolar, and they wonder, is there a different problem? But it's very, very common to have mood swings in a depressive episode as well. And obviously the mood swings aren't as extreme as they are in a bipolar disorder, which is a different mood disorder. That word anhedonia is losing that interest and motivation in doing things and in life. And as I mentioned earlier, that social withdrawal is a really important mood change. Their physical changes can include lots of sleep difficulties, actually. So for some, they may have difficulty falling asleep, and we call that initial insomnia. For others, they can't stay asleep, and they may have interrupted sleep all night. And another very important symptom is early morning wakening, which is waking at least an hour before your normal wake-up time, and when you don't need to be awake. So many would describe lying in bed from 5 a.m. or 6 a.m. unable to go back to sleep. And then this usually does lead to a lot of fatigue, low energy, and often that reduction in appetite. There's very important cognitive changes as well. Often there's a lot of worry and ruminating thoughts, thinking about things again and again, feeling bad, maybe feeling helpless or hopeless. And there's a lot of concern that the young people start feeling really guilty and feel that maybe life will never get better and everything is bad because of them. They usually always have difficulty concentrating, sustaining attention and focusing, which is often why some of these difficulties come out in school. There could be increased distractibility and an inability to focus on a task, distortions in thinking, and morbid kind of ideation, really sad, negative thoughts, as well as suicidal ideation. So the effects of depression on the thinking processes often means that they're slowed down and reasoning can be distorted, so they can jump to conclusions, think the worst about situations, and misinterpret things. So often that can be the cause of some of the irritability or the stress, because they may feel if something happens or when you say something to them that the way they hear the message is actually that you're blaming them or that you think they're bad, whereas it may be just completely their own perception of what you've said if you're trying to help them. Often adolescents can't cope with these intense low feelings, and they'll do other things to get escapism and to actually feel better, even if it's a temporary relief and even if it's something dangerous. So as well as doing things like drinking and taking drugs, they can also do things like drive fast cars or do really, really risky, dangerous things, because if they're going with that negative type of cognition that life is hopeless and it's not worth it, they'll often take more risks than they would normally, which is really concerning. So the good news is there's a lot of treatment options, and it depends on the young person and what the presentation is as to which is the best for them. The first thing is always psychoeducation, so it's helping the young person really understand what's going on, what's happening. It's a huge relief sometimes for them to have a diagnosis and to actually realise that there is actually a problem. Understanding the symptoms and also noticing how it affects them and how maybe things are harder for them when they're not well can be a big relief as well, especially with attention and concentration, maybe trying to do schoolwork. There's lots of types of psychotherapy, and I'm going to talk a little bit about cognitive behaviour therapy, the CBT, and family therapy. There's also a lot of medication options, And there's also behaviour activation, which is a type of therapy as well, but it's actually one of the ones that people can start doing by themselves and can use self-help books to do as well. Sleep hygiene is really, really important. And then obviously if there's any other environmental problems, for example, bullying or things you know about in the family, it's really important to address those. So the first one that I'm going to talk about is actually how you approach doing any of the therapies. Basically, you've got to have adolescents on board before you try and do any of the treatment options. And one of the great things about working with adolescents is that they keep you on your toes all the time. They'll ask you about everything, and they tend to want to be really involved in their treatment. And we work really, really hard to make sure that they absolutely understand everything, including all their choices, even though for young people under the age of 18, we obviously legally need parental consent for all the treatment options. And it's really important to empower the young person that they're going to be in charge of their mental health problem and that they have choices. And we put a lot of work into that at the start, and I feel that helps young people to really be able to take on their own recovery, and it gives them great confidence at being able to do that, because it can be quite a helpless, lonely feeling when they are depressed. So it really depends on how much they can engage at the start as to which type of help they're going to be able to accept. Sometimes they won't want anything, and sometimes kind of a lot of conflict can happen. So it's really trying to bring them on board with the psychoed first, that they'll actually admit that there is a problem, that there is something they want to change. Because often maybe the first consultation is a parent has brought the young person maybe to see us in the clinic, or that they're worried about them and the young person doesn't even want to talk. And often trying to do something really collaborative and finding out something that they're worried about or something that they want to change or do different, that can be the start. And they have to have the autonomy and the right to different choices. And then there can be great resistance to wanting the different treatments, whether it's a talking therapy or medication, and really working on what the resistance is about. And it's often fear. Young people might be afraid. They might be afraid of taking medication. They've read something on the internet. They know a friend who had a bad reaction, and really trying to understand that and being flexible, and really listening to what they have to say. And that, I think, makes a big, big difference at the start. I thought I'd just talk a little about cognitive behaviour therapy, because it's one of the therapies that probably a lot of people might have heard about, and it's one of the ones we'd use a lot with adolescents. And the aim is to reduce psychological distress and maladaptive behaviour by altering the cognitive processes. And mood and behaviour are largely a product of thought. So basically, doing either a cognitive or a behavioural intervention can bring about changes in thinking, feelings and behaviour. So what I have up here is just we call it the dysfunctional cycle, when things aren't going well. And these are the sort of thoughts, feelings and behaviours that someone has when they're depressed. So the thought could include being overly negative, very self-critical. And I mentioned earlier that when someone's depressed, they select what they hear when they hear things, so they often have a biased view. So they might hear things in a negative way or really catastrophise. And there's a tendency sometimes to generalise things as well. So if one thing goes wrong, they think everything's going to go wrong, and that nothing gets better. And there's a lot of that negative thinking. Those type of thoughts lead to all those really unpleasant feelings, which usually would include feeling depressed, sad, anxious or angry. And as a result, often they'll give up things in their behaviour. They may stop going out, they may refuse to talk, and they may refuse to eat, and different things can happen. And basically, if you work on either the behavioural or the thinking process, you can actually bring about quite a lot of change. And it depends on what they're able for as to which to do first. So often working on the behaviour and helping them see the link between their thinking and their feelings is the right thing to do. And for others who really like looking at the cognitive side of it and understanding their thoughts and where they come from and working that out, that'll work better for them. And you're trying to basically make it what's called a functional cycle, which is that the link between thinking, feelings and behaviour, that they actually can understand that and that they can see. So the way that they do it is that they experiment and they try different things. So it's either practical behavioural experiments or it's actually intellectual ones that they're thinking about, and there's absolutely loads of different ways of doing it. I just said I'd mention a few. So one of the main parts of the treatment is actually monitoring, so they get to understand what's happening, and when they understand the link between thinking, feeling and behaviour, that's a really, really good start. So there's a big part about psychoeducation, then understanding what the problems are. The next thing is identifying and picking out those times that there's selection bias, that they're interpreting things maybe in a negative way, and then that they believe that that's true and that's the only truth. So it's trying to help them actually really see, is there an alternative explanation? Is that really a fact? Can they test that? Can they try that out? And once they get the confidence to try and do that, they can start developing new skills. And it's really, really empowering when it works and they try one thing and it works and then they try another thing. And they can actually learn a lot of skills which will help them manage the depressive episode and prevent them from having another depressive episode as well. And the really nice thing about it is it can be done at home or in hospital, depending on how unwell the patient is. A really important part of the formulation, which is the understanding of how the young person became depressed, is linking things like early experience, core beliefs and assumptions. Assumptions are things that you jump to, that you actually believe, and it's from previous things that have happened. Dysfunctional thinking styles, or thinking about critical incidents. So something bad might have happened before, and someone might think that nobody likes them, and that they may think that they're unlovable, and that means nobody would ever love them, and the whole thing can escalate. And a lot of negative automatic thoughts that they may think that they're boring and nobody would want to talk to them, then they don't talk to anybody themselves, and that'll lead to that cycle of them then avoiding a social situation or being there, and no one might talk to them if they don't talk to anyone, and then they'll have had a bad night. So it's looking at all of those things, and it's a very effective therapy. The next important treatment that I wanted to mention was antidepressants, and it's really interesting that often there's a lot of resistance and concern by parents for putting their young people on antidepressants, which is really understandable because of maybe fear or concerns they have about side effects of medication and what it will do and how it will change things. And we would always try and use therapy first, and if therapy isn't enough, then we move to therapy plus medication. We never just use medication on its own in adolescence. And in particular, there are two neurotransmitters, which are brain chemicals, that we understand that the antidepressants work on. And I'm not sure if people have heard of serotonin, but that's one of the main ones, and noradrenaline as well. And I was going to go through how the serotonin medications work, because they were the most common, in a minute. I just wanted to mention about family therapy, because that's really important in adolescence as well. Looking at relationships and roles in communication, it's really important to have that explored in detail. And sometimes when we recommend family therapy, families are concerned that we think they're the problem, whereas actually it's not that. It's actually because they're going to be the biggest support for the young person. And some families, yes, there is family problems, but in other families, they're actually going to be the best support for the young person if they understand how to help them maybe do their CBT, how to help them monitor their mood, and how to look for triggers and help them actually manage. So understanding all of that can actually make a huge difference for the young person and for the families to actually understand their young person. And obviously, if unhelpful interactions are picked up, and if there is negative or I suppose high emotion and critical comments, helping work on that relieves a lot of stress and tension at home as well. So I was going to talk a little bit about selective serotonin reuptake inhibitors, and these are the most commonly prescribed types of antidepressants. Most people probably have heard about Prozac, which is probably one of the medications that we use the most. The chemical name for it is called fluoxetine, and it's actually there's only 2 antidepressants licensed in under 18s for depression, but we often have to use other medications, and this one is the fluoxetine is the one that is licensed. And it's really important that children and adolescents are really closely monitored when they start medication. There's a risk of emergence of suicidal thinking, sleeplessness, agitation, or some withdrawal from normal situations. The risk is highest actually usually within the first 2 days to the first 4 weeks. So this is the highest risk time when we start medication, and we'd always recommend having a review within 4 weeks of starting medication. It's been approved by the FDA, which is in the States, as treatment for major paediatric depressive disorders. So children as young as 6 and 5 and 6 often are put on it, and it is actually licensed. Even though I've listed a lot of side effects, most young people don't get them, but we always inform them so that they're informed before they take it, so they wouldn't panic if they did have any. The most common is nausea, and usually it doesn't lead to vomiting, and that's a very temporary side effect, and it usually goes. And we find that we can avoid that by starting at a really, really low dose. So the smallest tablet is 20, so we'd usually start in a liquid, and so we can go lower than 20, and we titrate it really, really slowly. And I'd say it happens about once a year that we'd have someone who has a side effect by doing it really slowly like that. So once parents and young people know that there's a small risk of some stomach upset or headache, they're the 2 most common. It tends to actually be much easier and much less stressful for them, because if they have it for a day, they actually know that it'll go away. And then obviously rarely there's more serious side effects. There is sometimes a concern about a thing called discontinuation symptoms, which is if you come off the medication too quickly, there's a risk of getting agitated or feeling shaky. And this is avoided by carefully titrating the dose down, the same as the way you titrate it up. So we find that we can do it without either the problem starting it or ending it if it's done slowly. The physical symptoms for the discontinuation syndrome can include headache, dizziness, nausea and sweating, rarely irritability or agitation. There's one other problem with these medications, that akathisia is an inner sense of restlessness, and this can occur, and teenagers are more likely to get this than adults actually, because they're considered fast metabolizers, which means that the medication goes through the system really quickly. And if this happens, it usually means they need to come off that particular medication. It doesn't mean they can't ever try this type of medication again, but it means that this one isn't going to suit them. So it's really important that you've told them that beforehand, so it can quickly be addressed, because it's unpleasant and it goes quickly. As I mentioned, that often young people are faster metabolizers, so they have a higher risk of these type of symptoms. There's been a lot of controversy and concern that the SSRIs, the selective serotonin reuptake inhibitors, can increase suicidality. There's been a lot of papers and a lot of research done on this, and the basic message is that they don't, and it's really important to treat especially moderate and severe depressive episodes properly, which does include medication. And there's a lot of trials and there's a lot of research into it, and there's no doubt that some have increased suicidal ideation in the first day or two, and that's been shown in a few of the studies, but it doesn't lead to completed suicides. And later on, as this has been looked at, the longer term studies show that there isn't an increase in suicides with increased prescribing. A longer term treatment, for example, all treatments really should be at least 6 months with antidepressants. There's actually a reduction in suicide attempts, and antidepressant use is associated with decreased risk of suicide and death. And that's been shown actually in multiple studies. So even though we have to, when we're doing informed consent, let people know there's a rare chance there's going to be an increase in agitation or suicidal thoughts, it's actually also a very important treatment for depression. There was a very important study which was called the TAD study, which is the Treatment of Adolescent Depression study, and it was a multi-site, which meant it was in lots of different places and countries, looking at Prozac on its own or Prozac with cognitive behaviour therapy. And there was 439 adolescents in the study, aged between 12 and 17, and the results of this showed that fluoxetine, which is Prozac, plus CBT was the most effective treatment, and this is also in guidelines in quite a few countries as well. So this is kind of the gold standard first treatment for young people with moderate depressive episodes. I've done that. So the other thing I just wanted to mention was the level of youth suicide in Ireland is the 5th highest in Europe, and it's really very high in males as well, less than 35, age 35, accounting for about 40%. And there's a very concerning trend that alcohol consumption is really very, very commonly present in episodes of self-harm and in completed suicides as well. And there's a peak in presentations in casualties from midnight, especially on Sundays actually, and early Monday mornings as well. So that's a real risk factor and something that is addressable and treatable as well. So I mentioned earlier behavioural activation, which is something that can be done without actually always going to a therapist. It's something that young people can do at home and the parents can help young people do. And basically, it's a treatment for depression that basically, it's not just the internal factors like the cognitions, it's also the actual doing and the behaviour that might be maintaining a low mood. So basically, it's actually literally trying to activate the young person's behaviour. So they do have to do some monitoring, so they have to look at what they're doing. And maybe some of the things they're doing, for example, staying in bed till 3 o'clock or 4 o'clock and not eating and not getting up and not getting dressed, this could actually be maintaining a low mood. And sometimes going and doing an activity can make them feel a lot better. And research has shown as well that doing activities that are pleasurable and that they enjoy will actually give them a small little brief lift in their mood as well, rather than staying in, being isolated, not doing things. And the really important part of behaviour activation is picking goals that are really achievable. So it could be a very small goal like get up and play on the computer or the PlayStation for an hour rather than being in bed for the day. It might have to start with things that you don't want to become bad habits as well, just to get a change happening. And then you build up towards goals that they need to be able to do. For example, if young people are out of school, sometimes going back for 1 hour, 2 hours, 3 hours, that's all really, really important. And when they do something that they like, if they see an improvement in their mood, then they'll actually start wanting to do it again, and that'll lead them to doing the behaviour again. So, as I mentioned earlier, it's really important to treat depression because there's actually a really high risk of other associated problems, and this can actually include educational as well as antisocial behaviours as well. So what to do about supporting young people? It's really important not to criticise or blame them, and not to say anything that would make them feel worse than they feel already. Even if they are causing a lot of hassle and tension and making family life very difficult, it's really important to be really, really empathic. And the other really important thing is any small change, even if it's a really small thing and it doesn't work, it's really important to acknowledge it and note it and encourage the young person. And don't expect them to snap out of it, because they would have if they could have, and they can't, even if it looks like they can. And one thing that parents sometimes get really frustrated about is the young person could be really low and moody at home with them, but then manage to go out for a little while with their friends or go on the phone or go on PlayStation, and they think that means they're not depressed. But actually we actually read into that the other way. It's really good that they can get an hour's break, or that they can do that, and we'd be trying to build that up, but also build up other things that they have to do over time. And then obviously encouraging healthy relationships as well. The other thing that's really important for parents is once they can understand their adolescents' difficulties, they need to mind themselves, because parents can do so much trying to help and trying to fix things that they actually sometimes end up not sleeping well themselves, not eating well, not actually minding and caring for themselves, and that can make it really hard then to support someone who's really unwell. Just really basic things like exercising, relaxing, taking breaks, and that can make a really big difference. When to refer for help. If the child is suffering, and if they're telling you that they are, or if you see a big change in their functioning, so that could be either through school or through their social life, if they're absolutely not meeting anybody, if they've started becoming quiet, locked in their bedroom, and if they're losing interest in, as I mentioned earlier, pleasurable activities, or if there's thoughts that life isn't worth living, they're the kind of the real warning signs to go and get help and get an assessment. And usually the first place is to go to, if you're really worried, the GP is a good person to start with first, and they can advise you then about the different options. I've just put up a list of books that some parents find helpful as well, just some resources, and there's some for young people as well, because often people we can put them up on the, I think the talk is going to be up on the Aware website anyway, so if anyone wants those. And there's an awful lot of support out there. So Let Someone Know is a site that young people use a lot. Teen Text, Inspire and Reach Out, actually I should have put up, are really, really helpful. Headstrong as well, the National Youth Organisation, and obviously Aware as well. So thank you very much for your attention.